the field of epilepsy diagnostics and treatment. Epilepsy is a major health burden in India. Of the estimated 70 million people with epilepsy worldwide, nearly 12 million people with epilepsy are expected to live in India, which contributes to nearly 1/6 of the global health burden. This conference serves to bring together experts who can share groundbreaking insights, discuss emerging trends, and explore cutting-edge advancements in epilepsy care. Throughout the course of our program, you will have the opportunity to delve into a diverse array of topics through which we aim to foster a collaborative environment conducive to learning, networking, and ultimately improving patient outcomes. I would like to extend my deepest gratitude to our distinguished speakers whose expertise and dedication continue to drive progress in this field. I would also like to thank our chairperson and advisor for their invaluable support in making this conference possible. To all the attendees, I encourage you to actively engage, ask questions, and share your experiences throughout the duration of the conference. In closing, I wish you all an enlightening and rewarding experience at today's CME. May our collective efforts inspire hope, foster collaboration, and propel us towards a future free from the burden of epilepsy. Thank you. I now invite Dr. Preetham, Assistant Professor of Department of Neurosurgery, to open and give us an overview of the program.
A warm welcome to everyone. So at the outset, I would like to take a few minutes to talk about International Epilepsy Day. The second Monday of every February is celebrated as World Epilepsy Day. That is, it falls on 12th this year, and we are conducting a CME on that occasion. So it is organized by the International Bureau for Epilepsy and International League Against Epilepsy. It's a part of WHO initiative. The initiative being the 10-year intersectoral global action plan on epilepsy and other neurological disorders, shortly called as IGAP. So they have set two targets for 2031. The first target being the countries will have increased service coverage for epilepsy by 50% from the current coverage in 2021. And the second target being 80% of the countries will have developed or updated legislation with a view to promote and to protect the human rights of people with epilepsy. So the main barrier in achieving these targets is the low level of literacy and misconceptions regarding epilepsy. So this ignorance and misconceptions can lead to social stigma, which leads to discrimination of people with epilepsy at workplace, school, and at communities. At the healthcare level, it can also lead to misdiagnosis, inappropriate treatment decisions, inadequate care, and also at the government level also it hampers the resource allocation. So the theme for this year is the milestones on my epilepsy journey. So the people with epilepsy and those who care for epilepsy are asked to share their epilepsy journey on the social media with these hashtags. So that is the Epilepsy Day and My Epilepsy Journey hashtags. So the International Epilepsy Day website has these formats for sharing the epilepsy journey. These are for the patients with epilepsy, so they can tell their story regarding how they developed courage and resilience, the story of defying expectation and breaking the stigma. So there are also formats for epilepsy caregivers, so they can share the facts regarding epilepsy on social media on this occasion. So at Vydehi Institute of Medical Sciences, so we are conducting these programs to increase the awareness regarding epilepsy. The first is the update on epilepsy CME that we are conducting today. And there was a poster making competition for MBBS students. The posters are displayed outside, and the prizes will be distributed today. And we had conducted a skit for public awareness. So now I hand over to Mariam, who will introduce our first speaker of the day. Thank you.
Thank you, sir. We now welcome Dr. Akshita, HOD and Professor of Department of General Medicine, to introduce the speakers. I also welcome Dr. Suresh, Professor from Department of Radiology, to chair and moderate the first session.
Dr. P.C. Mohan, Professor and HOD, Department of Neurology. He has done his BA in Neurology from Liman Institute, following which his work as consultant neurologist in various hospitals in Bangalore, like Maria Lakeside Medical Center, Apollo Sagar, SSNMC, and Global Clinic Hospital. He also worked as assistant and associate professor in the Department of Neurology in Dr. B.R. Ambedkar Medical College.
ಆಫ್ ಮಾಡಿದ್ದೀನಿ.
Has worked as professor and HOD in neurology from 2009 and 2000 to 2012, during which he started graduate in the college. He is also active member of Indian Academy of Neurology, member of Neurological Society of India, and president of IMA East Branch in 2005. I now call upon Dr. P.C. Mohan sir to begin the session.
Thank you, Madam, for your kind introduction. First of all, I would like to thank our chairperson, Madam, our advisor, sir, our principals, and others, managing committee, ethics committee, and superintendent AOs for giving this platform to celebrate the International Epilepsy Day. Dr. Pritham has told about what is International Epilepsy Day. We also know that we also celebrate National Epilepsy Day on 17th November each year, again to increase the awareness of epilepsy and increase the improve the quality of life of patients and their families. I would like to thank Dr. Anant Kishan, organization chairman, Dr. Pritham and Vishwanath, organizing secretaries, for inviting me to talk on overview of epilepsy. So I will be talking under the following headings: history, epidemiology, pathogenesis, etiology, types of seizures, classification of epilepsy, diagnosis, management, and prognosis, and prevention and conclusion. I will be briefly touching all these aspects because following me, there are experts who is talking on particular type of epilepsy surgery, refractory epilepsy, and imaging studies and every other things. As you know, epilepsy, the term is derived from Greek term epileme, that is to possess, to take hold of, or to seize. Epilepsy is one of the oldest recognized conditions with written records dating back to 4000 BC. In the Vedic period, 4500 to 1500 BC, ancient medicine refined and developed basic concept of epilepsy. Charaka Samhita, which was Ayurvedic literature in 400 BC, describes epilepsy as apasmara, meaning loss of consciousness. Hippocrates, more than 2400 years ago, he said that this is not a sacred disease, but it is a disorder arising due to abnormalities in the brain. He describes some physical treatment and also stated it is an incurable chronic illness. Ibn Sina in 2000 AD describes epilepsy as brain disease. But the modern epilepsy studies and literature is from in 1873 by Hughlin Jackson, a neurologist of London, who described relationship of electrochemical discharges arising in the brain and seizures. Hans Berger in 1920, who was a German psychiatrist, developed EEG to measure brain waves and its application in the field of epilepsy. For long, fear, misunderstanding, discrimination, and social stigma have surrounded epilepsy for centuries. There are pervasive myths that epilepsy is a contagious, incurable disease resulting from morally bad behavior or demonic possession, which can keep people isolated from and discourage them from taking treatment. As you all know that epilepsy is a non-communicable disease which affects all ages, and people of epilepsy and their families suffer from stigma and discrimination. Globally, about 5 to 6 million people are diagnosed with epilepsy and needs active treatment. Nearly 70% of people epilepsy live in low and middle income countries. The risk of premature death in epilepsy patients is 3 times higher than general population. It has a significant economic implications in terms of healthcare needs, increased prevalence of death, and loss of work productivity. The incidence of epilepsy is 0.5 to 1%, whereas the incidence of seizures is about 5 to 10%, and at any given time 10% of the population have at least one seizure episode in their lifetime. Epilepsy can affect any sex or any age in the world, and it is more common in children up to the age of 10 and also in people over 60 years of age. So what is seizures? Seizures are sudden, uncontrolled episodes of excessive electrical discharges in some neurons of the brain with associated sensory, motor, or autonomic changes with or without loss of consciousness. This seizure is a symptom of epilepsy. Seizures occurring in a setting of acute illness or medical condition like fever, hypoglycemia, metabolic disturbance are described as acute symptomatic seizures. Convulsions are defined as sudden, violent, irregular jerking of body due to involuntary muscle contraction with or without loss of consciousness. It is possible to have seizure without convulsions and vice versa. Epilepsy is defined as is a common neurological disorder characterized by recurrent unprovoked seizure occurring on 2 separate occasions at least 24 hours apart. An isolated single attack of seizure does not imply epilepsy. Cluster of seizures is considered as a single seizure for the purpose of diagnosis of epilepsy. So epileptic syndrome is defined as a constellation of signs and symptoms with characteristic easy findings and which occur at particular age, and they have got a different treatment management. So how do the seizures occur? Neurons are interconnected in a complex network. Each individual neuron is linked with hundreds of neurons via synapses. Neurons discharge electrical current and neurotransmitters are released at synaptic level and permits intercommunication. Neurotransmitters are of 2 types. One is inhibitory neurotransmitters and excitatory neurotransmitters. Inhibitory transmitters like GABA acts on ion channels and increases chloride outflow and decreases chances of action potential formation. Excitatory neurotransmitters like aspartate and glutamate allow sodium and calcium influx, which paves the way for prolonged action potential formation. In this manner, information is conveyed, transmitted, or processed throughout the brain. A normal neuron discharges repeatedly at low baseline frequencies. If neurons are damaged or injured or suffer a chemical or metabolic insult, the changes in the discharge pattern develops. During epilepsy, regular flow frequency discharges are replaced by bursts of high frequency discharges followed by periods of inactivity. A single neuron discharging in an abnormal manner is usually not clinically significant, but when a whole population of neurons are discharged synchronously in an abnormal manner, seizures are precipitated or occurs. This abnormal discharge may remain localized or spread to adjacent areas, recruiting more neurons as it expands and causing again seizures. So when there is abnormalities in the ion channels, sodium, potassium, or calcium, and associated with a decreased inhibitory activity or increased excitatory activity, there is repetitive hypersynchronous discharge of neurons. And this causes seizure focus, and this focus can cause seizures, and which can cause repetitive seizures and can form a epilepsy focus. So what is epileptogenesis? Epileptogenesis is a sequence of events that converts a normal neuronal network into a hyperexcitable network. Epileptogenesis is the process by which a brain network that was previously normal is functioning altered toward increased seizure susceptibility, thus having an enhanced probability to generate spontaneous recurrent seizures. Secondary epileptogenesis. In secondary epileptogenesis, area becomes epileptogenic because of the influence of epileptogenic activity in a primary epileptogenic area, which is separated from it by at least one synapse. A mirror focus is a type of secondary epileptogenesis in which the secondary epileptogenic zone is located in a contralateral homotopic area with regard to the primary epileptic zone. Secondary epileptogenesis is likely due to kindling. So, what are the causes of epilepsy? The most important causes of epilepsy are, it is idiopathic in about 50% of the patients, and due to genetic studies, now more of the cases have been made due to genetic causes. Unknown 15%, infection, degeneration, cancers, head injury as high as 9%, and congenital malformations and stroke of various types can cause seizures in about 10 to 15% of the patients. What are the common seizure triggers? Most importantly, missed medications in the epileptic patient is the most triggering factor. Stress, anxiety, hormonal changes like increase in estrogen or decrease in progesterone level can cause seizures, especially in women. And during menstruation, dehydration, lack of sleep, extreme fatigue, photosensitivity, illicit drugs, alcohol, and certain medications like penicillin, INH, and chloroquine. ILA classified the seizures in 2017, which is expanded version. They said it is a focal onset, generalized onset, unknown onset, or unclassified. In the focal onset, they are again reclassified as if the sensorium is normal, aware, and if it is abnormal, impaired awareness. In that, motor onset, automatisms, atonic, clonic, epileptic spasms, hyperkinetic, myoclonic, tonic, or non-motor onset, autonomic, behavior arrest, cognitive, emotional, sensory, or focal, becoming to secondarily bilateral tonic-clonic seizures. In generalized onset, it can be again motor, tonic, clonic, clonic, tonic, myoclonic, myoclonic, tonic, myoclonic, atonic, and epileptic syndromes, and non-motor like absence seizures, typical absence or atypical, myoclonic or eyelid myoclonia, which is a new class, comes under new classification. In unknown onset, motor could be tonic, clonic, epileptic spasms, neonate, non-motor could be behavior arrest, or there are still so many epilepsies which are unclassified. This probably is difficult to see. International classification of epilepsies, epileptic syndromes, and related disorders. Here, I will just read out the main headings. Localization related, like focal, local, or partial, which could be idiopathic or symptomatic for temporal lobe epilepsy, or which can occur in other lobes like parietal or occipital lobes. And cryptogenic, then generalized, again it could be idiopathic, that is benign neonatal familial convulsions, and childhood absence epilepsy, and cryptogenic or asymptomatic, then epilepsy with myoclonic astatic seizures, then symptomatic, again secondary non-specific etiology like early myoclonic epilepsy, again undetermined epilepsies with both generalized and focal onset like neonatal seizures, and special syndromes associated with febrile convulsions or any other located seizures. So, I will just briefly explain what is earlier it was called partial seizures, now it is focal seizures. Here consciousness is preserved, which occur within discrete regions of the brain and cause motor, sensory, and autonomic or psychic symptoms. Partial motor seizures, it occurs due to seizure activity in the precentral gyrus. Motor seizures affect contralateral face, arm, trunk, or leg. Movements typically could be clonic or pure tonic. Seizures may localize to one part or may spread to involve the whole brain when it is called secondarily generalized seizures. There may be Jacksonian seizures where motor seizures begin in a restricted part of the limb such as fingers and gradually progresses over the complete whole limb within seconds to minutes. Torse palsy may occur due to paresis of an involved limb which can last from minutes to hours. Epilepsy partially continua. Here seizures may continue for hours, days, or sometimes months. Somatosensory seizures. In somatosensory seizures, focus is in the contralateral post-Rolandic convolution, described as numbness, tingling, and pins and needles feeling. There may be sense of crawling, which is called formication, and electric-like sensation may be there. Sensation of movements of the parts may also be seen. Spatial sensory seizures like visual seizures, here the focus is in the occipital lobe, and there are sensation of flashy flight or seeing colored objects. There may be visual hallucinations, and auditory seizures, which are characterized by buzzing or sensation of human voice repeating in the ears, or there may be vertiginous sensation, or there may also be auditory hallucination. Olfactory seizures, which can occur due to lesions in the inferior medial temporal lobe or uncus, characterized by change in smell or foul smell. Focal seizures with impaired awareness, which was called complex partial seizures earlier. Here aura is in the form of simple partial seizures, which has a period of altered behavior or altered consciousness with amnesia to the event. Objects may appear smaller or bigger. Visual and auditory hallucination may be seen. There may be cognitive states like deja vu, where the patient feels he is familiar with the surroundings. There may be fear of anxiety, sense of rage, followed by sudden behavioral arrest, accompanied by automatism in the form of lip smacking, chewing, or swallowing or flubbing of hands. During the episode, patient is not in contact with the surroundings, typically confused, and take few minutes to hours for recovery of the consciousness. In partial seizure with secondary generalization, this can spread to both hemispheres and produce generalized tonic-clonic seizures. Sometimes it is very difficult to distinguish from primary generalized tonic-clonic seizures. This is a figure showing different parts of the different parts of the seizure occurring, like if they are previous okay, there was a figure showing different parts of the brain, like if they are coming with the temporal lobe, there may be auditory hallucinations, or if they are arising in the olfactory lobe, there is a change in the smell or bad smell, and if they are olfactory lobe, there may be hallucinations of the visual hallucinations, different types of seizures occurring due to the occurring in the different parts of the brain. Generalized seizures, they arise from both cerebral hemisphere without any focal onset. In that, absent seizures, which is common in children of 4 to 8 years of age, which is characterized by sudden loss of consciousness without loss of postural tone or control. There is rapid fluttering of eyes, chewing or clonic movements of hands may be seen, which lasts briefly for 10 to 20 seconds, and there is no post-ictal confusion, and it manifests as unexplained daydreaming or poor performance in the school, and EEG may show 3 Hz per second spike and vivid discharges. Spontaneous remissions during adolescence occurs in more than 70% of the patients, and they respond well to sodium valproate or ethosuximide or sometimes lamotrigine. Okay, thank you. Atypical absence seizures, in that loss of consciousness is longer, and EEG shows 2.5 Hz per second, which is associated with diffuse structural brain abnormality, and it is less responsive to treatment when compared to typical absence seizures. In atonic seizures, there is sudden loss of muscle tone lasting 1 to 2 seconds. and patient falls to the ground, there may be head dropping or jaw dropping, and brief impairment of consciousness is there, which cannot be sometimes not noticed. There is no post-ictal confusion, usually seen in patients with other epileptic syndromes. Myoclonic seizures, these are we all experience physiologically while during the onset of sleep. Pathologically, they are seen in association with metabolic disorders, degenerative CNS diseases, or anoxic brain injury, or Creutzfeldt-Jakob disease. It coexists with other form of generalized epilepsy, like generalized seizure disorder in the case of juvenile myoclonic epilepsy. There is sudden and brief muscle contraction involving one part of the body or whole body. EEG shows bilateral synchronous spikes, polyspikes, and wave discharges, which is synchronized with the myoclonus. In generalized tonic-clonic seizures, it is characterized by premonitory phase, ictal phase, and post-ictal phase. In the premonitory phase, there is vague premonitory symptoms which may be present, and patient may feels that the seizure is going to happen. In the ictal phase, which can occur without any imminent warning. In the tonic phase, this is characterized by tonic contraction of muscle throughout the body. There is extension of back, neck, and legs, and this is accompanied by loss of consciousness, uprolling of eyes, and pupillary dilatation. There may be ictal cry due to tonic contractions of muscles of expiration and larynx, which produces a ictal cry. Air is forcibly emitted through the closed vocal cords. Respiration is impaired, secretions, pool, and cyanosis may develop. There may be tongue bite or increased sympathetic tone, leading to heart rate, increase in heart rate, BP, and pupil size. The tonic phase usually lasts for 30 to 60 seconds, which is followed by clonic phase. In the clonic phase, involuntary convulsive movements of all limbs, jerking occurs, which may also involve jaw and facial muscles. Breathing becomes again stertorous. There may be incontinence, which this phase may last for 1 to 2 minutes. In the post-ictal phase, which is characterized by flaccidity and unresponsiveness, consciousness gradually regained over few minutes to hours, followed by post-ictal confusion. Patients may complain during this period. Patient may complain of headache, or fatigue, or muscle aches. EEG during tonic phase reveals progressive increase in general low voltage fast activity, followed by general high amplitude polyspike discharges. In the clonic phase, high amplitude activity is typically interrupted by slow waves to create spike and wave pattern. The post-ictal phase shows slowing of EEG. Epileptic syndrome, this is a different in epileptic syndrome is defined by type or types of seizures like absence, GTS, or there may be multiple seizure types, and it occurs at a particular age, and etiology are also different, and degree of neurological and intellectual deficits are high. There is clinical evolution of the epilepsy, and EEG, they have a characteristic EEG pattern and also neuroimaging abnormality. In the neonatal period, there may be benign neonatal seizures or benign early myoclonic epilepsy or Ohtahara syndrome. In infancy, there is West syndrome or myoclonic epilepsy of infancy. And in childhood, febrile plus seizures are seen, and early onset childhood occipital epilepsy, there may be epileptic encephalopathy with continuous spike and wave discharges, Landau-Kleffner syndrome or childhood absence epilepsy may also be there. Benign epilepsy with childhood with centrotemporal spikes, it is common characteristic features include unilateral somatosensory involvement, there may be speech arrest or preservation of consciousness in most cases may be seen. There is pooling of saliva or tonic-clonic spread to the seizure may be present. Benign epilepsy of childhood with centrotemporal spikes, the typical inter-EEG shows centrotemporal spikes or slow waves which are either unifocal or bifocal. They respond well to carbamazepine. They have a good prognosis. In West syndrome, there is a triad of seizures, psychomotor retardation, or specific EGC changes, which is known as hips arrhythmia. It usually occurs in the first year of life. There may be flexor or extensor spasms or mixed, both the things may be there. These are usually resistant to treatment with, they may be, some people may respond slightly to steroids, but the prognosis is poor. In Lennox-Gastaut syndrome, it has a mixed seizure disorder. EEG may show slow or spikes and wave discharges. Commonly, it needs polytherapy and prognosis is usually poor. Differential diagnosis of epilepsy. Any condition which causes episodic impairment of consciousness can be a differential diagnosis of epilepsy. Or any seizure, any involuntary movements can be a differential diagnosis for epilepsy. One of the most common differential diagnoses could be TIAs, syncope, metabolic disturbances due to hypoglycemia, sudden increase in intracranial pressure, sleep disorders, or any movement disorders, or psychologically related phenomena like psychogenic non-epileptic seizures. These are all common. Also in patient may have true seizures and also PNES, which may becomes difficult to sometimes to diagnose which was a true seizure and which was a psychology non-epileptic seizure. So in we do routine investigations like KFT, LFT, CSF examination, and lactic acidosis in some patients. But the most important diagnostic criteria is thorough neurological examination, and most important among that is thorough medical history from the patient and the eyewitness who has witnessed the seizure. This is the most important feature when we try to diagnose the epilepsy. EEG helps in tracking the functional and electrical signals from the brain with EDO EEG, which can localize the seizures and sometimes can differentiate pseudo seizures from true seizures. Magnetoencephalography can help, and CT and MRIs can detect abnormalities in brain like tumors, bleeding, cysts, gliotic areas, focal cortical dysplasias, and metastases or arterial any blood vessel malformations. Functional MRI, PET scans, SPECS, or nowadays genetic testing is coming in a big way. For so many epilepsies, we are having genetic testing. This is a EEG showing left T3, that is a temporal lobe focus, which can be a part of focal seizures, left temporal lobe focal seizure. Just show. This is showing spike and wave 3 Hz, this thing which can be suggestive of generalized seizures like absence seizures or any other seizures. Now, this MRI is showing where the arrow is focused is focal cortical dysplasia. I will not go into detail because the other speakers are going to talk this thing. A normal MRI, again a focal cortical dysplasia. This focal cortical dysplasia is common cause of focal epilepsy in children, and MRI findings could be subtle cortical or subcortical signal, or may show cortical thickening, or there may be transmental sign. Now coming to the management of the patients is very important. Not all patients whom you treat will not respond. So, but what are the goals of treatment? The goals of treatment is to control and reduce seizure frequency, to focus on minimum possible dosage of anti-epileptic drugs, to minimize ADRs, that is adverse drug reactions associated with therapy, to ensure patients' medication compliance, to reduce mortality and morbidity, to ensure the patient's normal lives as far as possible. So when we are considering or choosing anti-epileptic drugs, we have to consider seizure type, what is the type of seizure, type of epilepsy syndrome, what is the efficacy of that particular drug in that epilepsy or seizure type, and cost, because you cannot prescribe very expensive drugs, otherwise there will be poor compliance, and pharmacokinetic profile and adverse effects. Mechanism of action of anti-epileptic drugs, there can be sodium channel blockers like phenytoin, carbamazepine, lamotrigine, or lacosamide, and calcium channel blockers which can prolong chloride channel by opening by barbiturate is one of the examples, and also opening benzodiazepines or block synaptic GABA reuptake, for example tigaben. Synaptic vesicle protein 2A modulation is done by levetiracetam. Estrazolamide is a carbonic anhydrase inhibitor, and there are multiple pharmacological targets which is where sodium valproate and topiramate, jonosmide and rufinamide act on the multiple sites. Choosing AEDs on basis of mechanism of action. It is logical to choose drug with different or novel mechanism of action than existing drugs. Multiple seizures type benefit with drugs having multiple mechanisms, and there is no evidence that one AED is superior to another based on the mechanism action alone. So these are the drugs of choice for specific seizure tours. In partial seizures, first line of drugs are carbamazepine or oxcarbazepine, diphenylhydramycin, lamotrigine or valproic acid, and alternative drugs could be gabapentin, topiramate, levetiracetam or jonissamide, tigaben, primidone, phenobarbital, felbamate or lacosamide. In absence seizures, again valproic acid and ethosuximide, or alternative drugs could be, if they don't respond, then lamotrigine or levetiracetam are indicated. In myoclonic seizures, again valproic acid and clonazepam are the better drugs first line. Then subsequently we can use lamotrigine, levetiracetam, topiramate or jonissamide. In tonic-clonic seizures, again diphenylhydramycin and valproic acid, which is a broad spectrum anti-epileptic drug, levetiracetam, which is used more frequently nowadays, and lamotrigine, topiramate and oxcarbazepine are also used as alternative drugs. This is commonly used anti-epileptic drugs where we use day in and day out most of the patients in regular seizure patients, not in refractory epilepsy. Valproate, the dosage is 60 milligram per kg in 2 to 3 divided doses. Levetiracetam 1000 up to 1500 milligram twice a day. Topiramate 125 to 200 milligram in divided doses. Lamotrigine 75 to 200 milligram in a divided. Perampanel 4 to 12 milligram. Clobazepam 10 milligram BD. Carbamazepine 600 milligram twice a day. Up to doses, we need not use all these at that dosage. We can increase in the small dose and increase depending upon the recurrence of seizures. Oxcarbazepine 1200 to 4400 milligram per day. Phenobarbital up to 180 milligram per day. Phenytoin up to 300 milligram per day. Lacosamide 100 to 200 milligram per day. These are the common anti-epileptic drugs we use in the seizures who respond to the drugs. In case of refractory epilepsy, there are other drugs which my subsequent speaker will definitely going to educate us. So consideration of AEDs, again the same thing. I will just omit this slide. In absence seizures, ethosuximide again. Whereas in choosing the drug in case of syndromes, in childhood absence epilepsy and other absence seizures, ethosuximide, lamotrigine or valproic acid, other drugs also lamotrigine can be used. And juvenile absence epilepsy or other absence epilepsy, ethosuximide, lamotrigine. And juvenile myoclonic epilepsy, lamotrigine, levetiracetam, valproate or topiramate. And genetic generalized epilepsy, lamotrigine, valproic acid, topiramate and levetiracetam. In Pantopoulos syndrome, they respond well to carbamazepine, but the drugs in Landau-Kleffner and other diseases, they don't respond, and we may have to subject to other anti-epileptic drugs. So when you choose the drugs, anti-epileptic drugs, when you use one single drug in a newly diagnosed epilepsy patients, first drug in a moderate dosage or the maximum dosage, 47% of the patients become seizure free. And when another 50% of may have recurrence of seizures, during that time we will add another drug, and that drug can reduce seizures in another 13 to 15% of the patients. And when they don't respond to two drugs, either either single or in the combination, then we use third drug with a rational polytherapy. And here you use any number of drugs, again 6 to 8% of the patients may become seizure free. But another 30% may remain refractory to any number of anti-epileptic drugs, and these patients are subjected for other modes of therapy like surgical treatment and also vagal nerve stimulation and other modes of therapy. In spite of doing all these things, with surgical treatment, with other modes of treatment, 5 to 10% of the patients may remain refractory to epilepsy. These are the unfortunate patients where we may not be able to completely stop the drug seizures, or may to some extent reduce the drugs, reduce the seizure frequency. There are a lot of side effects of anti-epileptic drugs. Most of the side effects occurs with all the anti-epileptics, like the commonest are dizziness, fatigue, ataxia, diplopia, irritability, which can occur with any of the anti-epileptic drugs. Levetiracetam may cause behavioral abnormalities. Topiramate may cause weight loss or anorexia, and valproate may cause congenital abnormalities if given in a pregnant lady, and weight gain also, and carbamazepine and gabapentin also may cause weight gain. There are certain special idiosyncratic drug-related effects, like renal stones can be occurred due to when you use topiramate or jonissamide, and acute glycoma can be a cause of topiramate, and carbamazepine and oxymazepine can cause hyponatremia, which is a common side effect. There are certain serious adverse reactions to drugs like aplastic anemia, which can be caused by felbamate. Nowadays we are not using felbamate because of this very serious side effects. Jonissamide, valproate and carbamazepine also may cause aplastic anemia. Hepatic failure is caused by valproate, lamotrigine and phenobarbital, and gabapentin can cause peripheral loss of vision. When they don't respond to anti-epileptic drugs, then we also consider diet. One of the common diets prescribed is ketogenic diet. This is, we have a lot of experience in case of using in children, especially with multiple seizure types. Likely anti-seizure effect of ketosis is due to beta hydroxybutyrate, but other mechanisms also be responsible for beneficial effects. It is a low or very minimal carbohydrate diet with adequate protein and high fat. And here 50% of the patient respond by reducing 50% of the seizure reduction, and 30% may have more than 90% reduction. Side effects include kidney stones, weight loss, acidosis and dyslipidemia. But many children may not tolerate this ketogenic diet for a long time. Vagal nerve stimulation. Patients with intractable epilepsy, 35% of patients have 50% reduction in seizure frequency, and 20% experience 75% after 18 months of therapy. Epilepsy surgery is considered when not responsive to medical management, or there are unacceptable seizure control despite maximum tolerated doses of 2 or 3 appropriate drugs, either as monotherapy or polytherapy. Some may be curative, like resection or epileptic region when the focus is removed, or some we do it as a palliative surgery, and callosotomy is done to prevent the spread of seizure to the other side of the brain. Discontinuance of anti-epileptic drugs. This is the most challenging task when you face. Whenever a patient comes that I don't have seizures for 2, 3, 5 years, it becomes very difficult to definitely ask him to reduce or taper. But we should try in all patients who are seizure freedom for more than 2 years, where there are 60% chance of successful withdrawal in some of the epilepsy syndromes. The favorable factors are if their control achieved easily on one drug at low dose, and if there are no previous unsuccessful attempts at withdrawal, and if there is normal EEG and normal imaging studies, and if it is primary generalized seizures except in JME, and if it is a benign syndrome. So there are certain non-drug treatments like adequate sleep is very much important, and avoidance of alcohol, stimulants, and avoidance of known precipitants like stress reduction and specific techniques. Prevention of seizures is very important because 25% of the estimated population of epilepsy can be potentially prevented. That is done by preventing head injury, by reducing falls or road traffic accidents and sports injuries. By providing adequate perinatal care can reduce cases of epilepsy caused by birth injury. Prevention of CNS infections like TB, neurocysticercosis and encephalitis. Prevention of stroke, hypertension and cardiovascular diseases. Avoiding alcohol and illicit drugs. So in conclusion, epilepsy is a very complex neurological disorder. Most of the patients with epilepsy achieve seizure freedom and can live a normal and productive life. Seizure medications are the main treatment of modality. Diet therapy should be considered in some cases. Some patients may require surgery and other modes of treatment. Refractory epilepsy is a challenging condition for management. 70% of people with epilepsy could live seizure-free if properly diagnosed and treated. Appropriate community and medical care should be taken to prevent epilepsy. Most of the cases of epilepsy are diagnosed and classified with advancement in investigations like EEG, MEG, MRI, functional MRI, and SPECT and nowadays genetic studies. Thank you.
Thank you, sir. Thank you for such a lucid presentation on epilepsy. Right from Vedic days to the modern era, now the house is open for discussion. If there are any questions, you can please ask. Please hand over the mic.
Food. Some very rarely patients may, while eating food, they may get seizures. This is called reflex epilepsy. Very rarely. I must have seen one or two patients in 25 years. We read, but in practically we see, I have just seen one some 15, 20 years back when I was in the men's. Or some presentations are there when you attend the conferences. Very difficult.
In our rural area, the Jodhpur, we are having actually one child.
Okay, madam.
So that child we referred here also. I don't know, still they are having the same problem.
Okay. Do they have any particular type of food or any whenever he starts eating food?
It occurs sometimes only, not always.
Always.
And after 1 or 2 days, child becomes okay.
Okay.
Drugs have been prescribed, but they are not continuing it now.
Sir, your overview is really comprehensive and excellent.
Thank you, sir.
If you permit,
Thank you. Yes, please, sir.
the previous slide, can you just show the previous slide?
Yeah.
See, Monday, this coming Monday, is celebrated all over the world as International Epilepsy Day. Second Monday of February of every year, all over the world. Open has highlighted that point.
Yeah.
So, those of you who have cell phones, take a picture of this competition and then send it to your friends. It's very, very, to understand epilepsy, you need one book. I think this conclusion, one
Thank you, sir.
slide, it gives all the information. You just share it with your friends. You may have a person with epilepsy, you may have a friend, you may have a family member. Just if with your effort, if you send to your friends, it will have a multiplier effect. So many people will know, those who are not here, those who are not attended, also will know about all those things. If they are interested, they will find in Google about more details.
Thank you, sir.
Is there any more questions? If there are no questions, yeah, please, sir.
I just want to add what my colleague told. Like he said, we thought it is reflex epilepsy.
Yeah.
is surprisingly quite common.
Okay.
If you elicit the detailed history,
Oh.
like he said, he might have seen 2 or 3, but I have seen about at least 10.
Okay.
So it may vary from person to person, but when you take a detailed history, it's quite, it's not like
Yes.
infrequent. That's what
Maybe. Maybe it all depends upon where, like you are in a NIMANS or in a government setup, probably you may see more cases. I have seen 1 or 2 patients when I was in NIMANS, afterwards maybe 1 or so. But he attend conferences where they present this thing. But I have seen just 3, I can say.
If there are no questions, I have one small,
Yes.
very basic question.
Yes.
Sometimes we see patients with epilepsy on roads and so on. Suddenly they give some metallic objects, keys and so on. What is your advice?
So
to the general
all those things
population?
are
Is there any scientific reason?
absolutely no. See, sir, what happens is any seizure which lasts for 2 to 3 minutes, tonic phase, clonic phase, and it starts by, if it is limited 2-3 minutes, and by the time you find iron rod or key chain or whatever this thing, that 2-3 minutes is over. So it is just coincidental that he gives the key chain and that seizure stops. But as far as yes, yeah, yeah, yeah,
Dangerous.
all that is required is turn the patient
yeah.
preferably to his left side. Okay, it will go off on its own. If it doesn't subside within 2 to 5 minutes, take it to the hospital.
See, earlier days, so much of for epilepsy patients was they were humiliated and other things, burned, or even the chappals and other things are kept in the mouth or so. I mean, so much.
Extension of the same question, sir.
Yes.
You know, epilepsy prevalent in low socioeconomic status and rural population,
Yeah.
uneducated. This is a lot of myths and beliefs.
Yes, yes.
And they relate to various even position disorders. Okay. When do you refer these patients for psychiatric counseling, sir?
See, any patients who comes to us, actually, if they are not drug poor complaints, they are having recurrent seizures and with low IQ, or if they have any myths like this, all these patients we routinely refer, sir. We routinely refer. We will take counseling for all patients, especially in cerebral palsy patients with seizures or any syndromes with patients. One is counseling to the patient, but counseling the family is very important. Because in children and all, you cannot counsel the child. The family counseling is very, very important.
Okay, sir. Thank you, sir.
Thank you,
for such an informative session.
Thank you so much, sir. I now request Dr. Suresh to introduce our next speaker.
Our next topic is imaging in epilepsy, that is by Dr. Ravi Vaisala. Dr. Ravi Vaisala is our professor in the Department of Radiodiagnosis. He's done his graduation and post-graduation from prestigious Bangalore Medical College. He was a formerly professor and head of the department at St. John's. He had worked here for almost 3 decades. Presently has joined us since 2022. Sir has vast experience in imaging. He has numerous publications in national and international journals, and he has done extensive research on hippocampal volumetry and diffusion tensor imaging in epilepsy. Over to you, sir.
Thank you, Dr. Suresh, for the nice introduction. Revered chairpersons and your delegates, a very good morning. At the outset, I would like to thank Dr. Anant Kishan and the organizing team and my head of the department, Dr. Suresh, for giving me this opportunity to talk on this occasion and to share what radiology has to offer with respect to drug-resistant epilepsy. Now, going to the patient's responses in epilepsy, we have those which have spontaneous remission and remission with epileptic drugs and drug resistant epilepsy. So, the first two is not what we are concerned. In imaging, we are more worried about this drug resistant epilepsy. So, the terminology, this was being called intractable epilepsy earlier, and now with the recommendations of the International League Against Epilepsy, it is changed to drug resistant epilepsy. So, what are the causes of intractable epilepsy or drug resistance epilepsy? We have MTS, mesial temporal sclerosis, developmental causes like focal cortical dysplasia, heterotopia, polymicrogyria, hemimegaloencephaly, schizencephaly, epileptogenic tumors like ganglioglioma, DNET, pleomorphic xanthoastrocytoma and hypothalamic hamartoma, scars sclerosis, and miscellaneous conditions like Rasmussen's encephalitis and cavernous hemangioma, and neurocutaneous syndromes like Serge-Weber syndrome and tuberous sclerosis. This is a pictorial representation of the same thing of what I showed just now, and most of the causes are mesial temporal sclerosis and focal cortical dysplasia. So, role of imaging in drug resistance epilepsy is to identify the structural and functional abnormalities underlying the drug resistant epilepsy. So, what are the modalities? The modalities are a routine brain MRI, and we have some modifications of this like SBGR and MPRAG. These are gradient echo sequences specifically for certain conditions. We have fluid attenuated invasion recovery and susceptibility weighted imaging, hippocampal volumetry, MR spectroscopy, diffusion weighted imaging, DWI, and diffusion tensor imaging and fiber tracking, and functional MRI, and we have intraoperative MRI, what's called IMRI. This category is MRI based. Does CT have any role at all? As far as drug resistant epilepsy is concerned, CT has no value. At the most, in acute phases, it can be used for detecting hemorrhage or as an adjuvant where we need to pick up calcifications. The next group is the functional neuroimaging with PET and SPECT. This is more of nuclear medicine. These are the following investigations: functional neuroimaging with positron emission tomography. We have flumazenil or FMZ PET scan. We have AMT or alpha methyl tryptophan PET scan, and we have functional neuroimaging with single photon emission computed tomography, or what's called SPECT. And this SPECT can be used for ictal and interictal spectral scan, which has a great value. Now, how do we classify the cases? We have MR positive cases and MR negative cases. MR positive cases, yes, we know what is there. There is a lesion. This is a lesional MR lesional case. This MR positive, MR negative cases are the ones which are challenging for the radiologist, because we need to really demonstrate what is happening there. What is the cause for a routine MRI may not show anything. So, this MR negative case, this category is what we needs to be evaluated. So, imaging source of the epileptiform activity in the brain is especially important for the patients with drug resistant focal epilepsy, as this provides clinically useful information for planning the surgical therapy. But it may not always be possible to pick up these abnormalities that are responsible for the drug resistant epilepsy, and a negative MRI is the one which should always be viewed with some suspicion. So what do? We need to do various modifications in our protocoling. So the MRI protocols. See, the usual protocols are the 6 T1 axial and coronal, T2 axial and coronal flare and susceptibility weighted imaging. These are the usual ones. But when we have a problem with identifying the cause for epilepsy, we need to modify it, and oblique coronal plane sequences in oblique coronal plane perpendicular to the long axis of the hippocampus is required for mesial temporal sclerosis. So in the normal case, the way we plan an MRI is different. But here, this particular protocoling helps us to evaluate mesial temporal sclerosis better. So these are the various things which I already have told. So now I will be going through the various conditions which are mentioned and also the different techniques and protocols. Simultaneously, there could be a little overlap. So the mesial temporal sclerosis. So mesial temporal sclerosis, MTS, is a specific pattern of hippocampal neuronal loss accompanied by gliosis and atrophy. Surgical removal of the visible MRI changes associated with unilateral mesial temporal sclerosis leads to seizure freedom up to 80% of the cases. So this is a case of mesial temporal sclerosis. Here we can see that in the coronal T2 and flare images on the right side, there is volume loss which indicates atrophy and causes secondary enlargement of the temporal horn. You can see here that there is volume loss and there is secondary enlargement of the temporal horn, and here you can see a hyperintensity in the hippocampus. So these are the primary and secondary findings in mesial temporal sclerosis. So we have atrophy. As I mentioned, there is atrophy and hyperintensity. There is atrophy and hyperintensity. And as a part of the secondary signs, we see enlargement of the choroidal fissure. These are all different cases, not the same patient. And we also have atrophy of the white matter there. There will be asymmetry in the hippocampus, in the mammillary bodies and in the fornix. These are the secondary signs. So to continue with MTS, we have this sort of subtle hyperintensity in the left hippocampus, and there is atrophy. You have hyperintensity and there is atrophy of the hippocampus. Now this is a case, just show how post surgery the case the slices would look. This is post surgery in a case of MTS. Now what are the differential diagnosis of hyperintensity in the hippocampal region? Yes, we have found hyperintensity, and are we too happy and to call it MTS? There we have to consider other things. Hippocampal hyperintensity can be there in other settings also. So hippocampal, the main differential diagnosis will be status epilepticus and a low grade astrocytoma or a DNET. So what happens in status epilepticus? There is going to be hyperintensity of the hippocampus, but there will not be atrophy. On the other hand, there will be enlargement of the hippocampus. That is what we need to keep in mind, and history is very important in these cases. So this is a DNET mimicking mesial temporal sclerosis. There is hyperintensity, and it's also described as to have the bubbly nature, but there is no atrophy. On the other hand, the hippocampus is swollen. The next condition is focal cortical dysplasia, and here this slide was already shown by the previous speaker. There will be subtle cortical and subcortical hyperintensities located in the deep sulci. There is blurred gray-white interface, focal cortical thickening, and the transmantle sign. So here we can see that there is cortical blurring over here, and the flare images shows subtle hyperintensities. This is the case of focal cortical dysplasia, and this is the transmantle sign. So, you can see there is a hyperintensity extending from the subcortical area to the margin of the ventricle. You can see here there is hyperintensity extending towards the ventricle. This is called the transmantle sign, and this finding is because of the arrested neuronal migration. We can have dual pathology, wherein in some cases here we see that there is hippocampal sclerosis, and here there is also focal cortical dysplasia. Then we go on to heterotopic gray matter, which results from arrested migration of the normal neurons, and the usual types, there can be two types, and this can be either subependymal or subcortical. And heterotopia, it shows up as nodular focal gray matter intensity in all the sequences. Here you can see subependymal nodularity with subependymal heterotopia. Here we have subcortical heterotopia. You can see the nodularity, the abnormal gray matter, and this is subcortical heterotopia. This is another case wherein in this case a routine MRI shows nothing. It is normal, whereas an SPGR sequence here, it shows the abnormal gray matter, abnormal subcortical dysplasia over here. Now we have oliguria. These are glial scars, especially this is due to a result of meningitis or some birth injury. These oliguria is specific type of a scar, and it has it results from the patient's the resulting patients that have shrunken cortex. The cortex is shrunken, while the deeper part of the cortex is shrunken more, as shown in this arrow. This is called oliguria. Then we have polymicrogyria. This is the condition wherein we see multiple gyri, multiple small gyri, and this is an anomalous, there can atrophy mainly posteriorly, and this can have anomalous venous drainage too. Then moving on to epilepsy associated tumors, we have ganglioglioma, DNET, pleomorphic xanthoastrocytoma, hypothalamic hamartoma. Coming to ganglioglioma, this typically presents as a cyst with enhancing mural nodule, but may be entirely solid also. Calcifications can be there, and we can see as a cystic lesion with an enhancing mural nodule. We have dysembryoplastic neuroepithelial tumor or DNET, wherein this is the one which has a bubbly cystic appearance, a swollen gyrus with bubbly cystic appearance, swollen gyri with bubbly cystic appearance. Pleomorphic xanthocytoma, xanthoastrocytoma, these are usually supratentorial and with extra enhancing mural nodule, and usually in the periphery there is going to be a meningeal contrast enhancement as noted in these slices. They have hypothalamic hamartomas. This is the hypothalamic hamartoma. So those were a few examples of tumors, epileptogenic tumors. Then we have other conditions like hemimegalencephaly. Hemimegalencephaly, where there is enlarged hemisphere with ipsilateral ventriculomegaly. The hemisphere is enlarged and mild ventriculomegaly is noted. Then we have Rasmussen's encephalitis. Intractable seizure activity in children can be there. Progressive atrophy of involved hemisphere and small hemisphere with a large ventricle. We have a small hemisphere sorry, we have a small hemisphere with a large ventricle. This can be epileptogenic. Then we have other conditions like tuberous sclerosis, wherein we have subependymal tubers. There are various other findings too. Sturge-Weber syndrome, mainly, this I have shown a CT here just to show the tramp track calcifications. So these were some of the conditions. Then moving on to susceptibility weighted imaging. How does susceptibility weighted imaging help us in evaluation of epilepsy? This will help us. This is an excellent tool for identifying lesions that contain calcium or iron and or hemorrhage, as in Sturge-Weber syndrome. Here we see a condition wherein a routine MRI is not showing anything, it is unremarkable, whereas susceptibility weighted imaging shows a blooming over here, which was later confirmed to be one this lesion was histopathologically confirmed to be some patients remaining seizure free after some time, and this was a cavernoma. This is another example of a cavernoma with blooming in susceptibility weighted imaging. Next, moving on to MR spectroscopy. So how does MR spectroscopy, this is another tool helping us to investigate epilepsy, drug resistant epilepsy. This will help us by identifying the metabolites, various metabolites, and what is important in MRS is the NAA, N-acetyl aspartate, is usually low in epilepsy. Here we can see that in this particular patient, this is a normal MR spectroscopy where this is NAA, whereas it is low in epilepsy. Then hippocampal volume measurements are there. That we can acquire volumetric images and we can measure the volume of the hippocampus either manually or using semi-automated or fully automated techniques. Here we see that the volume has been measured, and one is 3.1 cc, the other side it is 1.6 cc. So these are automated measurements of the hippocampal volume. This helps us in identifying the various conditions. Next, we have diffusion tensor imaging. Now, diffusion tensor imaging is a different sequence, is a technique where the diffusion of water molecules is considered. So here we take into consideration various aspects like fractional isotropy, mean diffusivity, and axial diffusivity and radial diffusivity. These are the values that are measured. These are measured to help us to locate the epileptogenic focus, and usually these values are less in areas affected with in the affected area. So this is how fiber tracking would look, and we have different color coding also for fiber tracking. Anterior posterior is green, left to right is red, and this horizontal one would be blue or purple. So this helps us to evaluate the integrity of the fiber tracts in the affected areas. How do we do this? Is it what MRI machine do we need? Do we need a 1.5 Tesla MRI or a 3 Tesla MRI? Yes, most of these techniques can be done in 1.5 Tesla, but certain conditions require a 3 Tesla MRI. This would be seen better in 3 Tesla. This is how DTI would look, and see, these are the we can take the measurements in these areas and the values will be shown up. Then we have functional magnetic resonance imaging or fMRI. This uses the sequence, what is called the BOLD, that is blood oxygen level dependent sequences. So, certain activities are performed like finger tapping, and what happens is when a repeated action is performed, the oxygen level increases and in between it decreases. So, there is a variation in the oxygen levels, and in between there is going to be a deoxyhemoglobin, and which has paramagnetic content. So, that helps us to pick up certain signals in the MRI that helps us in detecting the abnormal focus. This is BOLD MRI. This is how the image would look. Now, we have a whole series of functional neuroimaging with nuclear medicine, functional neuroimaging FDG PET, we have flumazenil FMZ PET, alpha 11C methyltryptophan AMT PET scan, and single photon emission computed tomography, and this can also be performed in the ictal and interictal SPECT scans. So, this is more of nuclear medicine, and in PET scan what is used is FDG PET, and this is how it is. In FDG PET, the affected area will be hypermetabolic. We can see that in this FDG PET, the affected side is hypometabolic. Then we have the FMZ or the flumazenil PET scan, and this also has a similar, this has something to do with the GABA agonist, it's a agonist, and this also is used to evaluate certain conditions. Then we have the FMZ PET. We can see that there is low uptake in the affected region, whereas FDG PET did not show anything. It was having normal uptake, whereas this had less uptake. We have this AMT PET scan, wherein there is increased uptake in the epileptogenic area. This is an image which shows increased uptake in the epileptogenic area. Then we have SPECT. SPECT is a single photon emission tomography with gamma rays, and usually 99 technetium M is the tracer. This is used in picking up certain conditions, and this particular SPECT can be used in ictal and interictal phases. So, in the ictal phase, this would have a hot spot. In the interictal phase, this will be as a cold spot, and this way, and not just this, there is also what is called subtraction of the SPECT with registered MRI, and this is called SysCom. So, what happens when subtracted, these two ictal and interictal, they are subtracted, we get to know differentiate the. These are the images of the subtracted SPECT scans wherein the focus is picked up better. I do not know much about this, it's more of nuclear medicine. Next, we have artificial intelligence. So, whenever there is an MRI case, there are certain trained discriminant classifiers which are trained in interpreting T1 and FLAIR images, and this artificial intelligence can help in detecting the lesion. Further, we have magnetoencephalography. Here, it is the measurement of the magnetic field generated by electronic activity of the neurons, and it is usually combined with a magnetic resonance imaging to get what is called the magnetic source imaging. This is how the equipment looks, and this looks like an open MRI wherein the patient is not going into a tunnel or anything, this is how the equipment would look, and this is the future of this particular this is how the investigation would look in magnetoencephalography. Subsequently, we have MRI, intraoperative MRI. This is the order of the day in many countries. See this here, there is a hybrid intraoperative MRI neurosurgery suite wherein the neurosurgeon will be operating under the guidance of MRI. It is not easy to do this because everything inside this has to be MR compatible. So such a thing has been devised, and this would be very promising for the future surgery. So what is the future of imaging in epilepsy? We have volumetric MRI. There is something called MRF, MR fingerprinting, that is evolving slowly. So this is going to help. Certain lesions will have their specific patterns. This again will be clubbed with artificial intelligence. And then we have magnetoencephalography. There is arterial spin labeling that is coming up. Then we have intraoperative MRI. This is the future of investigating the various conditions in drug-resistant epilepsy. So with this, I conclude my talk. Thank you very much. I thank the organizers once again for giving me an opportunity to talk, and also I would like to thank my residents, Dr. Sara, Dr. Kavya, and Dr. Puneet, for their inputs in this preparing this PPT. Thank you one and all for a patient hearing.
Sir, thank you for sharing your vast experience in MRI imaging. 1 second, please. Sir, I just want to add one point regarding, as you said, you beautifully brought out the extended spectrum of imaging in epilepsy, the additional thin sections and additional view. I just want one small point for the benefit of neurosurgeons here. We should add this one true inversion recovery sequence as a protocol in intractable epilepsy, because that's where most of the times we pick up heterotropias, and we have it as a protocol. This is just for info of our colleagues.
Yeah, thank you, Dr. Suresh.
Thank you, sir. The house is open for discussion. Yeah, you can please, if there are any questions, you can please.
How is an ictal spec done? I mean, during the epilepsy, ictal spec.
I really don't know how it is done. This is more of nuclear medicine. It's more of nuclear medicine. I think the neurologists will be in a better position to tell when they really refer it for an ictal spec.
Good question. Ictal spec is done in a video EEG monitoring unit. So we have patients of refractory epilepsy undergoing video EEG in a lab setup. The patients will be connected and they will be undergoing EEG with video for few days to weeks. So when the patient gets attacked, somebody has to sit in front of the patient round the clock, and whenever seizure starts, within 10 seconds we need to inject the tag. So once you inject it, after that we shift the patient to scan and do the image. So the earlier you inject the injection, the tag will be located in the onset zone, which is very close to the onset zone. If you delay it, it will be like widely distributed, so it will not give you much information. So it's a very cumbersome as well as it requires a lot of means the person who is sitting should be knowing what is the first feature of the epilepsy, like whether it is EEG is the first thing or clinically or it is what is first, that they should pick up and inject within few seconds. So many times it may not be possible, but whenever it is successful, it will give very good information, and it is required especially in MR negative patients to localize as well as lateralize the seizure. But what happens, we do the video EEG, patient gets attacks. Generally, we need 3 to 4 attacks to conclude the onset and localization in epilepsy. So when we are recording the first 2-3 attacks, we see how this patient is getting, where the EEG is showing, how the clinical features are there. So after seeing that, we will, based
Thank you, doctor.
Most of these seizures are focal hypomotor seizures. So it's not the primary generalized epilepsies that we do right now. So it's not a major problem.
Yeah, this question has another answer. When a patient who comes for epilepsy surgery is supposed to have frequent seizures. So it may not be that much of waiting. In cases where you don't get active seizure to record, before the surgery we precipitate the seizure by withdrawing the drugs gradually, slowly. Okay. And then injecting when a patient gets an attack. This could be quite dangerous, or it could be quite shocking to the patient attendants. It must be explained that we are ready with all the necessary treatments and it could be done. And all the time we are doing injections when patient is having a status epilepticus. Because it is not causing any damage. So it should not cause a damage in injection of a step life.
Your presentation is very informative. I
Thank
just
you.
want to add few comments. So first thing is the retrospect. It's really difficult to do retrospect. You know, in India, in Bangalore, so many MRI scanners, very few centers where retrospect is done. We don't do difficult things. So, one of the important points in doing retrospect is to study the seizure. You, like Ravi mentioned that you study seizures before planning to inject. If there is a slow evolution of seizures, some seizures will take time. Slowly, they progress. Only those seizures where we don't know where it is starting and ending, we inject. If it is very fast spread, we inject, slight delay, you can show some other place. It's like a vehicle car started here and going to the airport. Somewhere on the way you will catch it. So it's a labor intensive process. Second comment is many things you had in this presentation like magnetoencephalography, MR PET, intraoperative MRI. All these things are available in MX. They're not in America and in Europe. If anybody is interested, you are most welcome to come and visit our facility. The last thing is, just for the benefit of very young people, suppose you lose your cell phone in this room. What you will do to get rid of the cell phone? You will ask people, anybody has seen. If you have suspicion, you will search somebody. And also you see in that corner, there is a camera. There is a video camera there at that corner. So you search the CCTV, whether anybody has come, anybody has taken your cell phone. So you try multiple ways, Same thing we do for epilepsy patients. You don't know where in the brain tips are starting. So different ways we try. One is MRI. See, it's like CCTV, you see some person coming and then taking, like this MRI, we see where we suspect, is there any problem? Is there a tumor? Is there a scar? Is there a disease? That's how you have to look at all those things. They're all complementary. One will add to the other. By multiple ways, we try to find the culprit. Okay, thank you.
Basic question is about this. I want to ask the doctors. Thank you for inviting us to come and see your neck and function intraoperable MRI possible. I think youngsters should take the offer of the Professor Bhaskar to go and visit and see these gadgets which are all available in Bangalore itself. We are fortunate to have it in Bangalore.
Contact him only for facilitating the process.
Otherwise, like listening on the basic code to now we say 50% is almost idiopathic epilepsy. Now, when you stop with all these data, industry is available. When you call a patient as idiopathic, where you will stop? The basic question I have very different states. It's idiopathic or not? Because we don't know where to stop with the industry is available.
So idiopathic is basically syndromes. Most of these idiopathic generalized epilepsies are classified depending on the age of onset, starting from childhood absence epilepsy, and then you have juvenile age, juvenile myoclonic, juvenile absence epilepsy, and then you have idiopathic generalized epilepsy with only GTCS. So these kind of common syndromes are there. These can be identified based on the different phenotypes. Number two that helps you is electrophysiology. So electrophysiology, there are characteristic fingerprint kind of patterns that we identify in each. You take childhood absence epilepsy, you have classical 3 heads 5-wave activity, and you have both of generalized spike and polyspike in JME. So these kind of things, and with normal background activity. So these are the some clues that give us the syndrome is more of idiopathic generalized epilepsy. And good thing about these idiopathic generalized epilepsies are, these are in general, they are well controlled with one medicine in general. But there are 20% of patients with IgE syndromes or idiopathic generalized epilepsy which are refractory, and those patients will be little difficult to manage. And sometimes all these classical features which we described may not fit. Sometimes you may see some borderline cases. You may have doubt whether it is a IgE spectrum with the refractoriness to medication, or whether it is still some focal epilepsy with MRI negative. So that is a gray zone which needs little more investigations, like we do all these kind of workup sometimes, and based on other features, and sometimes even genetics also we will get it, and all these things. But that number is less. Hopefully it will not be a major problem in benign patients.
Thank you.
Thank you, sir.
I now invite Dr. Anand Kishore, HOD and Professor, Department of Neurosurgery, to felicitate our speakers. Thank you to all the speakers for all their valuable insights. Dr. Ravi, sir. Please accept this token as our appreciation. I request Dr. P.C. Moore to please join us on stage. Thank you so much. Please accept this as a token of our appreciation. We'd like to thank Dr. Akshita and Dr. Suresh. Can you please join us on stage as well? Thank you everyone for your patient listening. We now have tea served outside in the corridor, and we will break for a short 10-minute tea break. So please enjoy.